morning. We are, well, there we go. We're doing critical care concepts in endocrine nursing. And we're going to start out with diabetes insipidus, which is a water metabolism disorder, and it's caused by deficiency of ADH. ADH is also called vasopressin. And when ADH is lacking or absent, it allows filtered water to be excreted in the urine instead of being reabsorbed. So it causes excessive urination, excessive thirst, and fluid intake. These folks are thirsty. Let's see if we can get this to advance. Nope. Being stubborn today. All right. Just go like this. So, what are the manifestations? The manifestations of diabetes insipidus are possible pituitary tumors, hypothalamic tumors, cranial trauma, basal skull fracture. You see this sometimes with motor vehicle accidents. People didn't have their seatbelt on and they hit their head. Okay, cranial surgery, stroke. Certain medications can cause this, such as lithium, phenytoin, and alcohol. Okay. So causes of neurogenic or central diabetes insipidus. It's caused by inadequate synthesis or release of ADH, which is what I just was talking about. It occurs when an organic lesion of the hypothalamus or posterior pituitary partially or completely blocks ADH synthesis in the kidneys, transport, and or release. These organic lesions, causes of these include brain tumors, hypophysectomy, aneurysms, thrombosis, and of course infection. The onset of neurogenic diabetes is acute. It happens very quickly, and it involves progressive loss of nerve tissue and increased diuresis, polyuria, and polydipsia due to permanent loss of the ability to secrete adequate ADH. If it doesn't secrete the ADH, it cannot be absorbed and do what it's supposed to do in the kidneys. Excuse me. So, what are the manifestations of diabetes insipidus? Abrupt onset of increased urine output, polyuria, sometimes producing 4 to 16 liters of dilute urine per day. That's a lot. Extreme thirst, polydipsia, leading to fluid intake of 5 to 20 liters per day. Weight loss, dizziness and weakness because of the hypertension that they have. Nocturia, leading to sleep disturbances and fatigue. Signs of dehydration, such as fever and dry skin and dry mucous membranes. Hypotension and tachycardia. Change in their level of consciousness. Okay. So their diagnostic testing may show urinalysis, almost colorless urine with low urine osmolarity, 50 to 200 milliosmoles per kilogram. Milliosmoles are just a way of measuring water. Serum osmolarity is increased greater than 300 milliosmoles per kilogram. You should know that, okay? Urine specific gravity is decreased less than 1.005. Serum sodium is greater than 147 milliequivalents per liter. Right? So it's concentrated. Dehydration tests or water deprivation test identifies vasopressin deficiency, which differentiates nephrogenic from pituitary effects. Okay, so it'll tell them, which organ is being affected. So what is the treatment for it? until the cause of diabetes insipidus identified and eliminated, vasopressin or vasopressin stimulus is given to control balance and prevent dehydration. Treatment measures include hypotonic IV solution administration, 1 milliliter for every 1 milliliter of urine output to replace free water loss in urine. That's a lot. Medications, subcutaneous or IM vasopressin aqueous preparations, sub-Q, IV, or nasal spray, desmopressin acetate, DDAVP to maintain volume in the body. Okay, talk about blood osmolarity. So that's what it's talking about. You know, there's 300 milliosmoles. So, excuse me, vasopressin administration can cause hypertension, angina, and myocardial infarction due to vasoconstrictive effects of the drug, okay? Monitor the patient's cardiac status closely, including vital signs, cardiac rhythm, and hemodynamic parameters. Monitor urine output and urine-specific gravity. Monitor other output sources such as drainage tubes. Monitor daily weights, serum laboratory test results, and skin turgor. Assess the patient's level of consciousness. Assess the patient receiving vasopressin for signs of water intoxication, including drowsiness, headache, lightheadedness, seizure, or coma. Right? Notify the healthcare provider for practitioner immediately if any of these occur. All right, so that's it for that. Let's go to thyrotoxic crisis or thyroid storm. So this is a picture of the thyroid, and it shows you exactly what, it's a very small area. It's your part, this part of your throat. And right here you have your thyroid gland, the thyroid veins. Right here is the trachea. So the thyroid is on either side of the trachea, okay? This is your jugular vein, right? So let's move on. So what is thyroid storm? It's a life-threatening emergency in a patient with hyperthyroidism. It may be the initial symptom is a patient with hyperthyroidism that hasn't been diagnosed. The onset of thyroid storm is almost always abrupt and evoked by a stressful event, such as trauma, surgery, or infection. Causes: untreated hyperthyroidism, infection in the area, trauma, manipulation of the thyroid during surgery. You know, they might be operating to take off a thyroid tumor, or they may be actually operating on the parathyroid, which is in back of the thyroid, and they have to manipulate the thyroid in order to get to it. As common causes, pardon me, metastatic carcinoma of the thyroid, pituitary tumor screening TSH, diabetic ketoacidosis, and poor compliance with antithyroid therapy. So how is it diagnosed? Serum T3 and T4 levels are elevated. TSH level is decreased. Radioscope scanning shows increased uptake. CT scan or MRI may disclose an underlying cause such as pituitary lesion. A 12-lead ECG may show atrial fibrillation or that should be supraventricular tachycardia. Okay? Because both are re-entry tachycardias. Okay. All right. So, thyroid storm, signs and symptoms. It develops when there's a surge of thyroid hormones. Hyperthyroidism can result from genetic or immunologic factors. They usually have a temperature, 102 to 106. I shouldn't say temperature, I should say fever, 102 to 106. hypertension, tachycardia, tachypnea. Now you're noticing a pattern here. Everything is elevated. Agitation leads to seizures, psychosis, and delirium if left untreated. Because this condition affects the sympathetic nervous system, all findings will be increased, which is what I just said, okay? So, signs and symptoms, a patient in thyroid storm initially shows marked tachycardia, vomiting, and stupor. Other findings include irritability, vision, and cardiac disturbances, such as diplopia, tremor, tachycardia, and cardiac arrhythmias. They may be weak. They may show a sign for heat intolerance. They don't, they're always warm. They're always hot. So they don't want to be around any heat. Angina, shortness of breath, cough, swollen extremities, and exophthalmos, which is bulging of the eye anteriorly out of the orbit. Okay. So what immediate treatment is needed for a patient with thyroid storm, and that prevents death. And it includes beta-adrenergic blockers to block adrenergic effects. Propylthyracol and methimazole to block thyroid hormone synthesis. Possible corticosteroid administration to block conversion of T3 and T4, because we don't want them converting because they're contributing to the hyperthyroidism. Avoidance of aspirin because salicylates block binding of T3 and T4. So if you're doing the prior, we're talking about possible corticosteroid administration to block the conversion of T3 and T4, you do not want to take aspirin because it blocks that binding, okay? Reducing thyroid secretion, stabilization of cardiovascular system, application of cooling blankets for hyperthermia, stabilization of respiratory distress, decrease physical and emotional stressors, which control infection and fluid balance. Okay. Nursing care of the patient with thyroid storm, assess the patient's location, level of consciousness, and cardiopulmonary status. Okay. Monitor their vital signs and core body temperature, and institute cooling measures such as use of a hypothermia blanket. Right, that's important. Monitor ECG readings. Increased adrenergic activity may produce arrhythmias. Monitor the patient for signs of heart failure. Monitor IV fluids and fluid and electrolyte balance. Monitor the patient for high blood glucose levels. Excessive thyroid activity can lead to glycogenolysis. Provide a quiet environment. Everything is increased in these patients. We need to try and help them by treating them medically, with medicine, and also providing them with a quiet environment. Okay, diabetic ketoacidosis. So diabetic ketoacidosis is an acute complication of hyperglycemic crisis in patients with diabetes. It is a life-threatening complication that's most common in patients with type 1 diabetes and is sometimes the first presentation of the illness. What's the pathophys of DKA? It occurs when the body does not have enough insulin. And we know that insulin is what breaks down sugar into energy. When the insulin's not present to break down the sugar, our body begins to break down fat because it still needs the energy. So fat breakdown produces ketones, which spill into the urine and cause glucose buildup in the blood, thus acidifying the body. You see that, diabetic ketoacidosis, okay? Acidifying the body. Because sugar is not entering into our body's cells for energy breakdown, the sugar is being processed by the kidneys and excreted through the urine. As a result, the patient becomes dehydrated and our blood becomes even more acidic. Okay. So what are the causes of DKA? Infection, illness, surgery, stress, and insufficient or absent insulin. Okay. What to look for in DKA? So the patient may have a rapid onset of drowsiness, stupor, and coma. Other assessment findings include they'll be severely dehydrated, rapid and deep Kussmaul's respirations. They're trying to blow off the CO2 and increase the blood pH. Fruity breath odor due to acetone. Polyuria, polydipsia, and polyphagia. Weight loss, muscle wasting, because the body is starting to break down the muscle in order to get the energy that it needs to stay in homeostasis. Vision changes, recurrent infections, abdominal cramps, nausea and vomiting, and leg cramps. Okay. So what happens if diabetic ketoacidosis is not treated? And this occurs, it's breakdown of overproduction of ketones by the liver, and loss of bicarbonate leads to acidotic state. We were just talking about that. Right? The increase in CO2 produces acidosis, which leads to the loss of bicarb from ketones that are broken down in the liver. Okay. Occurs when diabetes type 1 is undiagnosed, physical stress, emotional stress, and known diabetic fails to take insulin, which sometimes happens with, especially with our teenage diabetic patients. They want to be like everybody else, like their peers. So they don't want to have to take insulin. And the insulin pumps are great now because they don't have to, stop and give themselves insulin injection. This does it for them. But there's still some that really are not compliant. So blood glucose greater than 250 to 800 milligrams per deciliter, okay? Blood pH less than 7.3. That's a good marker for differentiating diabetic ketoacidosis from HHNS, which is what we're going to go through next. So blood bicarbonate is less than 15 milliequivalents per liter. Ketones are present in the blood. Ketones and glucose are present in the urine. Electrolyte abnormalities, sodium, potassium, and chloride. ABGs are abnormal, and urine-specific gravity. All right, so how do we diagnose DKA? So it's a wide range of findings are used to diagnose it. Serum glucose is elevated 200 to 800 milliequivalents per deciliter. Serum ketone is increased. Urine acetone is positive. Arterial blood gas analysis reveals metabolic acidosis. Remember what I said. The pH is usually 7.30 or lower, and the bicarb is usually 15 milliequivalents or lower. Okay, that gives you the metabolic acidosis. Initially, normal potassium level or hyperkalemia, depending on the level of the acidosis. And then hypokalemia follows. Right? But initially, it's high potassium, and then it follows that the hypokalemia is evident. Electrocardiogram findings show changes related to hyperkalemia. Tall 10 to T waves and widened QRS complexes. Later, with hypokalemia, ECG shows flattened T wave and may show a U wave. Okay, so hyperkalemia, tall tented T waves and a widened QRS complex. Later, when they go down, their potassium decreases and they become hypokalemic, you will see flattened T waves and it may show a U wave. Okay, increased anion gap and serum osmolarity is elevated. Okay. So, how do we treat it? It requires immediate attention, usually admission into the hospital. Assess their mental status as a nurse, record intake and output, assess blood glucose and ketone levels throughout, treatment. ECG monitoring, they really need to be on a monitor. Assess cardiovascular and respiratory status, frequent measurement of blood glucose, and treat according to glucose levels with regular insulin IV or subcutaneous, but everyone that I've treated initially, in my practice, we had them on a IV drip. So may need to check every half hour to 1 hour. May need to check their blood glucose. The goal is to decrease the blood glucose slowly. Okay. So you also need to restore their fluid balance. Initially 0.9 saline, 1 liter the first hour, and you monitor. Regular fluids according to client status. Blood glucose is 250 milligrams per deciliter. And then when the blood glucose drops to 250 milligrams per deciliter, you add dextrose to the intravenous solutions, okay? Because we don't want them to bottom out. All right. Correct electrolyte imbalance. Hypokalemic potassium is added to the intravenous fluids and the levels are monitored frequently. Monitor cardiac system. You need to monitor for VTAC and VFib. Treat underlying condition precipitating DKA. Okay. So monitoring potassium while treating DKA. Why does it need to be monitored? We know that. Insulin causes the reuptake of potassium into cells. If a patient is already hypokalemic from excessive fluid and electrolyte losses, administering IV insulin will worsen their hypokalemia. Okay, so, and that will cause life-threatening dysrhythmias. Okay, that's important, all right? Okay. So how quickly should the blood glucose be reduced during the treatment of a patient with DKA? No more than 2 to 3 millimoles per liter in an hour. Okay. Anything greater than this puts the patient at risk for increased cerebral edema and hypokalemia. So you need to do it slow. Diabetes mellitus management, sick day management, teach the client guidelines to follow when sick, monitor blood glucose every 3 to 4 hours, continue to take insulin or oral hypoglycemic agents, consume 4 ounces of sugar-free, non-caffeinated liquid every 30 minutes to prevent dehydration, meet carbohydrate needs through soft foods, such as custard, cream soup, gelatin, graham crackers, 6 to 8 times per day if possible. If not, consume liquids equal to usual carbohydrate content. Test urine for ketones and report to provider if they are outside the expected range. The level should be negative to small. We're talking ketones. And also make sure that you tell them to rest. You want to call the provider, if whoever patient or say it's a family member or whoever are sick and they have diabetes, you want to call them for the following: blood glucose greater than 240 milligrams per deciliter, test urine for ketones if prescribed, fever greater than 38.6 centigrade or 101.5, does not respond to acetaminophen or lasts more than 24 hours. If you're feeling disoriented or confused, experience rapid breathing, vomiting that occurs more than once, diarrhea that occurs more than 5 times or for longer than 24 hours, inability to tolerate liquids, and illness that lasts longer than 2 days. So these are sick day managements. Hyperosmolar, hyperglycemic states. Okay, so the potential complication of diabetes type 2, life-threatening medical emergency, high mortality rate, characterized by plasma osmolarity, 340 milliosmoles or greater. The normal is 280 to 300, so they're hyperosmolar. That's where you get the first H, HHS or HHNS, both are. Blood glucose severely elevated, 600 or greater, and can be as high as 2,000. Okay, normal is 700 to 110. They have altered level of consciousness, severe dehydration. If not treated properly, it can cause coma or death. So what is the pathophysiology of HHNS? In patients with type 2 diabetes, it occurs as a result of glucose production, which is released into the blood, or glucose uptake by the cells, and that is decreased. If the patient does not drink enough fluids, or they drink fluids that contain sugar, the kidneys can no longer get rid of the extra glucose. When the cells don't receive the glucose, the fuel, the liver responds by converting glycogen to glucose for release into the bloodstream. Okay. The kidneys try to make up for high glucose levels that are in the blood by allowing the extra glucose to leave the body in urine. When all excess glucose molecules remain in the serum, osmosis causes fluid shifts. Okay. This draws the water out of the body's other organs, including the brain. The glucose levels in the blood can be very high as a result. The blood then becomes much more concentrated than normal. They have hyperosmolarity. Hyperosmolarity creates a cycle of increasing blood glucose levels and dehydration. Hyperglycemia leads to increased urine output and dehydration. The cycle continues until fluid shifts in the brain, leading to brain cell shrinkage, which, if left untreated, causes coma and death. Okay. This is most common in patients with type 2 diabetes, but can occur in anyone whose insulin tolerance is stressed. An infection is one of the most common causes, can occur in patients who have undergone therapeutic procedures such as peritoneal dialysis, hemodialysis, or total parenteral nutrition, TPN. And it can be result from an acute or a chronic illness. So the onset of HHNS is usually gradual and may not be noticed by the patient. Diabetic ketoacidosis is acute. It comes on very fast. HHNS is gradual. Okay. So the manifestations of HHNS are similar to those of DKA, but there are differences. Altered level of consciousness, lethargy to coma, neurological deficits, their hyperthermia, motor and sensory impairment, and seizures, dehydration, dry skin and mucous membranes, and extreme thirst. As HHNS progresses, assessment findings may include that the patient is severely dehydrated, they're hypertensive, they're tachycardic, they have diaphoresis, they're tachypneic, polyuria, polydipsia, and polyphagia. They're lethargic and fatigued. They have vision changes, rapid onset of lethargy, stupor and coma, and neurologic changes. Okay, so the HHNS evolves very slowly, but then once, it's established in the patient, it can have rapid onset of lethargy. Okay? So diagnosing HHNS begins with serum glucose testing, but also includes several other evaluations. Serum glucose levels are elevated, sometimes 800 to 2,000 milligrams per deciliter. The ketones are absent, so there's no acidosis in urine. In urine and serum ketone results are negative. Urine glucose levels are positive. Serum osmolarity is increased. Okay, that's very important. Serum sodium levels are elevated, and serum potassium level is usually normal. Okay. ABG results are usually normal without evidence of acidosis. That's important. Okay. So how do we treat this? They're usually admitted to the ICU for care of this client since it's a life-threatening condition. They have an often altered level of consciousness, often unresponsive. Their focus in treatment is on correcting fluid volume deficits and electrolyte imbalances and addressing their underlying cause. Dehydration leads to increased plasma osmolarity. Often they are severely dehydrated. IV fluids are given to correct dehydration. Monitor fluid status and rehydrate with 1 liter of 0.9 normal saline solutions the first hour, and then monitor for rehydration. Okay. Administer isotonic or half normal saline as ordered. Lower glucose with regular insulin until the glucose level drops to 250 milligrams per deciliter. When the patient's blood glucose level approaches 250 milligrams per deciliter, add dextrose to the fluid to prevent hypoglycemia. IV insulin and electrolyte replacement therapy are delivered. Blood glucose levels are monitored. As blood glucose levels normalize, so do the sodium levels. Okay? And that's because we are no longer putting out large volumes of urine. And we know that sodium follows urine. So what we're trying to do is we're trying to stop that level of treat the underlying condition. Nursing care of the HHNS patient, assess the patient's level of consciousness and ability to maintain a patent airway, maintain respiratory status and oxygen saturation. Monitor the patient's vital signs. Changes reflect the patient's hydration status. Monitor the patient's blood glucose and serum electrolyte levels. Administer regular insulin IV as ordered by continuous infusion, and titrate the dosage based on the patient's glucose level, which are taken every hour until stable, or however it's been ordered by the healthcare provider. Remember, the patient with HHNS has severely elevated glucose levels. Less insulin is usually needed compared with that is required by patients with DKA. To reduce the glucose level because the patient typically secretes some insulin and may be sensitive to additional doses. Provide the patient and family education to foster prevention of future episodes of HHNS. So, syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH is a relatively common complication of surgery or critical illness, neoplastic diseases, pancreatic brain and prosthetic tumors, Hodgkin's disease, brain abscess, stroke, Guillain-Barré syndrome, pulmonary disorders, adverse effects of medication, chlorpropamide, probutamide, vincristine, cyclophosphamide, cyclophosphamide, haloperidol, carbamazepine, morphine, and thiazides. Adrenal insufficiency, anterior pituitary insufficiency. Physiology of SIADH. ADH is secreted excessively and the body responds by retaining water. Fluid shifts within compartments cause decreased serum osmolarity. Patient exhibits anorexia, nausea, and vomiting. Despite these symptoms, the patient may report waking. The patient reports being thirsty. Neurologic changes such as lethargy, headache, and emotional and behavior changes, and sluggish, deep tendon reflexes. Tachycardia associated with increased fluid volume and hyponatremia. Okay. So how do we diagnose this? Serum osmolarity is decreased. It's less than 280 milliosmoles per kilogram. Urine sodium is increased, greater than 20 milliequivalents per day. Serum sodium is decreased. So there you go, the salt's being washed out of the body. ADH level is elevated. So what is the treatment for it? It's based on the underlying cause and the patient's symptoms. Restrict fluid intake to 500 to 1,000 milliliters per day. Okay. Administration of 200 to 300 milliliters of 3% to 5% sodium chloride solution for patients with severe hyponatremia. A loop diuretic may also be ordered to reduce the risk for heart failure after administration of hypotonic sodium chloride. Okay. So what do we do as nurses? We assess the patient for neurologic, cardiac, and respiratory status. We implement seizure and safety precautions if the patient's serum sodium levels are dangerously low. Monitor the serum electrolyte levels, monitor the patient's vital signs, oxygen saturation, and cardiac rhythm for potential arrhythmias. Administer medications and IV fluids as ordered. If hypertonic sodium chloride is ordered, monitor for fluid overload and administer diuretics as ordered. Monitor the patient's intake and output and their daily weight. Enforce fluid restrictions and explain to the patient and his family why this is necessary. Okay, so here's some review questions. Patient is admitted to the hospital in thyrotoxic crisis. On physical examination of the patient, the nurse would expect to find, we're talking thyrotoxic crisis, everything is increased. So elevated temperature and signs of heart failure. Let's see. Rationale. A hyperthyroid crisis results in marked manifestations of hyperthyroidism with severe tachycardia, heart failure, shock, hyperthermia, agitation, nausea, vomiting, diarrhea, delirium, and coma. Although exophthalmos may be present in the patient with Graves' disease, it is not a significant factor in hyperthyroid crisis. Horseless and laryngeal stridor are characteristic of tetany, of the hypoparathyroidism, and lethargy progressing to coma is characteristic of myodexia coma, complication of hypothyroidism. Which of the following assessment findings characterize thyroid storm? Everything is increased. Okay, it's B. Increased body temperature, increased pulse, increased blood pressure. A nurse is planning to care for a client with a diagnosis of thyroid toxicosis, thyroid storm. Which of the following would the nurse include in the plan of care for the client? Cooling down the patient as soon as possible, restriction of fluid intake, B. C, administration of levothyroxine, Synthroid, or D, administration of enemas and stool softeners as needed. So it is A, cooling down the patient as soon as possible. So thyroid storm is a potentially fatal acute episode of thyroid overactivity characterized by high fever, severe tachycardia, delirium, dehydration, and extreme irritability. Because it is an emergency, thyroid storm requires heroic interventions for control. The high fever is treated with hypothermic blankets, and dehydration is reversed with intravenous fluid. Options C and D are treatment measures for hypothyroidism. That's this. Okay. C and D. Okay. Nurse is caring for a patient in DKA. Which of the following is used to determine the correct intravenous solution to administer to help with dehydration? The answer is B, corrected serum sodium levels. A is incorrect because serum potassium level is used to determine potassium replacement. Okay. B is correct because the determination of which IV fluid to use is based on the corrected serum sodium result. C is incorrect because white blood count determines if the patient has an inflammatory response to infection. And D is incorrect because the level of consciousness is not used to determine type of IV fluid to use. Okay, the patient is admitted with diabetic ketoacidosis, but has not been treated for type 1 diabetes. Which of the following should the nurse assess to determine the cause for this patient's current illness? I'll give you a chance to read those. Okay, the correct answer is D, concurrent infection. Because infection is a common cause of DKA, it is important to evaluate for the presence of infection when a patient with DKA presents to the hospital. Okay, the nurse is caring for a patient in DKA. Which of the following is used to determine the correct intravenous solution to administer to help with dehydration? And the correct answer is B, corrected serum sodium levels. The determination of which IV fluid to use is based on the corrected serum sodium result. The nurse is caring for a patient in a diabetic coma. Which of the following diagnostic data would indicate that this patient is experiencing HHNS? Correct answer is A, blood glucose level of 750 millimoles per deciliter. So in HHNS, the blood glucose is often higher than 600 milligrams per deciliter and can be as high as 100 milligrams per deciliter or higher. So Eat, Sleep, Study, Nurse 231, the end. Let's stop share.